So the webinar of today is about small animal, small breed dogs and also cats. And the question is, should we use osteotomies instead of the extracapsular repair if they have a cruciate ligament rupture? Let's start with some biomechanics so that you may understand why our patients could profit from an osteotomy of the proximal tibia. So we humans, we stand upright on our two legs, and you can see that in this position, the tibia plateau is parallel to the ground we are standing on. This makes sense because the tibia plateau is quite flat and the condyles are rounded. So this is a situation like a marble on a table. So if the table is parallel to the ground, the marble is not rolling off. So in this position, the ligaments which stabilize our own knees don't need to work. They can be relaxed. There's no stress. With our patients, the situation is different. They stand on four limbs and the hind legs are angulated, as you can see here. And to have the tibia plateau parallel to the ground, an angle is necessary between the tibia plateau and the tibia itself. And this angle is about 25 degrees in average. And this really gives, again, a tibia plateau which is parallel to the ground. So this has some advantages, and it came out from evolution. So the dog is a carnivore, or the cat. So originally they needed to hunt, and this tibia plateau parallel to the ground in this angulation of about 25 degrees gives them the best range of motion for running and jumping and getting their prey. And as you can see here from these prehistoric animals, this tibia plateau angle has been developed a very long time ago, millions of years ago, and it has not changed in our dogs and cats since these animals were alive. You can see they had the same tibia plateau angle, like this big saber-toothed lion or this pre-ancestor of wolves. So this tibia plateau angle gives an advantage when hunting. But it also comes with a price. And the price is called the cranial tibial thrust, which has been published and described first by the Slocums. So when the dog is standing and weight bearing, there is a permanent force pressing the tibia cranially. And this force has to be neutralized by the cranial cruciate ligament, which we can see here. So in a dog or a cat or a lion or another carnivore of this type, the cruciate ligament is permanently under stress during weight bearing. It doesn't matter if the dog is running or standing, there is always some weight on the cruciate ligament. So now we see a lot of patients with a cruciate disease, first maybe partial ruptures, then going into a full rupture. And at the moment, the reason why this is happening, why the cruciate goes into a degenerative disease and then finally ruptures, is this stress, this chronic overload during weight bearing, leading to first small partial damages, which is causing inflammation, and this inflammation is then triggering even more degenerative changes, and finally the cruciate ruptures. So it's not primarily a traumatic damage, it's a degenerative damage. A large dog normally shows up with this disease when they are 4 or 5 years old. Our smaller patients, cats and smaller dogs, they are normally older before they have this cruciate rupture. They are lighter, they have less body weight, so it takes longer until this degenerative disease ends in total failure of the ligament. The Cranial tibial thrust, this force pressing the tibia cranially and subluxating the stifle if the cruciate is damaged and broken. This cranial tibial thrust is also the reason why a dog or a cat cannot heal this problem. And this has been nicely shown in this study. These were dogs with a cruciate deficient stifle on one side, and they were followed with video fluoroscopy over 2 years. And the drawer, the anterior translation, was measured in these fluoroscopic radiographs. And you can see from the beginning, this dog had about 10 millimeter drawer, and after 2 years, it was still the same. So these dogs were not able to stabilize their own stifles. And this chronic subluxation will lead to degenerative joint disease. That's granted. You can tell this to the dog owner. If you don't do surgery, the dog will get arthrosis. And the menisci will also fail. The medial meniscus will get damaged with time because it is squeezed between the condyle and the tibia when the tibia is subluxating. This scientific background and this biomechanics did lead to a quite clear understanding that the larger dogs profit from a tibia osteotomy, which takes away this tibial thrust. So you see, this is a survey from the US, from members of the Veterinary Orthopedic Society, and here it's clear over 90% of larger dogs with a cruciate deficient stifle are treated by an osteotomy. When we look at the situation in the smaller dogs, that looks very, very different. So this is a published survey of British veterinarians, and here we can see only 1 of 7 smaller dogs with a cruciate rupture were taken directly into surgery. All the others, over 80%, were first treated conservative, according to this survey. And maybe if the result was not good enough, they started with surgery a few weeks later. And if they decided to go into surgery, 2/3 of the smaller dogs got an extra capsular suture to stabilize the stifle. And only a very small fraction had a tibia osteotomy for the treatment. So because this extracapsular suture is so popular around the world, I will try to give a little bit a critical look to this technique. First, we have to understand that the stifle has a very complicated motion. It's a so-called roll-glide motion. So partially during flexion, the condyle rolls from the cranial tibia plateau to the caudal tibia plateau, which you can see here. It's the same in humans. And because the tibia plateau is too short to have it completely rolling, there is also part gliding. So the condyle glides on the menisci and the tibia plateau. But in extension, it starts very cranial. In full flexion, it's very caudal. This has also the consequence that the angle between the tibia plateau here in blue and the patella ligament is not the same during motion. It changes. You can see here in extension, the angle is over 90 degrees. Then it gets a little bit smaller. It comes into 90 degrees where the stifle is neutral, and then it's smaller than 90 degrees. So it's permanently going from under 90 degrees to over 90 degrees. When the angle passes 90 degrees, the quadriceps muscle here, the strongest muscle in our body, starts to pull the tibia cranially, part of the cranial thrust. As you can imagine here, if this red thing is pulling, the tibia does subluxate. And then in flexion, if there's still weight bearing and the quadriceps is working, the tibia is pulled back. So after the cruciate is ruptured and the stifle unstable, we don't want to have this situation here or here. So we don't want this pull. So that's a part of all osteotomies, that we take away this force here, pulling the tibia cranially. But this roll glide motion has also another consequence. Not only that the patella tendon angle is changing all the time, we also have no center of rotation, no permanent center of rotation in our stifle, because the femur condyles are rolling back on the tibia plateau. So this means the center of rotation is on a line where it moves forth and back and forth and back. And the consequence is that if we place an extracapsular suture, wherever we place it, the distance between the fixation points, proximally and distally, will change, as you can see here. So if you use an isometric extracapsular suture positioning here, when the dog is flexing his stifle, the fixation point moves away here. You can see it's longer. So this means the material is stretched. And this is a cyclic stretching, which is very bad for every material. It will break with time. And you can see this stretching here in this study. So these are different type of extracapsulars with different fixation points. And there is a tension measure sensor in here. And then they measured the tension in the ligament during flexion here to also extension, flexion, and back. And they tried different angles of tightening of the material. And you can see whatever they have done in flexion, there is stress. Everywhere the material is stressed because it has to elongate. So there is no way we get a stress-free fixation. And there have been published studies. They looked at the materials we are normally using. Are they suitable for this type of cyclic stress? And the result is clear: no. None of the materials we are commonly using can take this cyclic stress without breaking. So the monofilaments leader line will be elongated permanently, so it is too long in the end and the stifle is unstable again. The stronger filaments of fiber wire type or so, they are not elastic enough, so they have a tendency to act like a cerclage wire, which is also not elastic, and they will break with time. It's just a question of the cyclic stressing. So we don't have good material, and despite that, it's a very, very commonly used technique. So let's see the results which we have. Published results, how good this extracapsular suture is working. And unfortunately, there is no results, long-term results in small breeds dog which have been measured on a force plate or other objective testing. There is a few studies with force plates in larger dogs. So extracapsular repair has been compared to TPLO osteotomy. And the first one was this one here with Labradors. And you can see, compared to a healthy hind limb, the TPLO gets quite a good weight bearing after about 5 months. The extracapsular is better than doing nothing, but it's not as good as the TPLO. So there is a significant difference. The same result in this study. Again, they compare TPLO with extracapsular in 80 dogs. They are randomly assigned. And again, the TPLO group has a better reaction force, ground reaction force, during the first year of healing. And also this study here shows that in the beginning here, the hind limbs are very asymmetric. That's clear. One leg is lame. Then there is a dip in function after TPLO and extracapsular, and then they start to improve. This is the TPLO, and you see the max peak force is reaching normal after a year. So left and right hind limb are used the same, but not the extracapsular. The extracapsular does not reach the same good result. Also the impulse, these legs are not so strong. So we can conclude that extracapsular suture is better than doing nothing, but it does not achieve the same results as an osteotomy. And if you look again, our small dogs have normally a higher tibia plateau angle. So it means the cranial tibial thrust is relatively larger in small dogs. So this puts a very high stress on this material. As long as we don't remove the cranial tibial thrust, the material has to take all the weight, and it is cyclic, overstretched all the time. So that's the reason why quite a lot of these dogs come back with unstable stifles after the suture has overstretched or did break. So the goal can be also in small dogs to take away this cranial thrust. And can this be done? Yes. There are studies published which looked at these osteotomies. And you see TPLO. A TPLO uses the red part of the patellar tendon angle here to reduce it to a max of 90 degrees. So here it's clearly over 90 degrees, generating the cranial thrust. So if we rotate the tibia plateau down, so the angulation will go to max 90 degrees, and there is no force anymore. So this is the idea of a TPLO. So there's no subluxation if you do it right. And you see, you can do a TPLO in small dogs. They have often a quite large TPA, so you have to rotate it a lot. So this is leading to a small contact area here to heal, and the tibia plateau is quite hanging caudally over the tibia. So that is caused by this high tibia plateau angle. And of course, there's not so much space to put in your screws. But it can work, as it has been shown. The same is with a TTA rapid. Here, the idea is not to use the red part of the angle. The TTA works with the yellow part. This is the patellar tendon. So the insertion is moved cranially until, again, the patellar tendon and the tibia plateau reaches a maximum of 90 degrees in full extension. So the stifle is neutralized. There's no force pulling here, and if the stifle goes a little bit in flexion, the quadriceps is holding the tibia back, so no subluxation. So here are results of publications in small dogs. Small dogs generally means smaller than 15 kilos, if you can see here. So this is a study with TPLO, good long-term results. This is tibial closing wedge osteotomy with 55 dogs. Again, good long-term results. The problem here a little bit is that the result is assessed by the owners, so there is no objective measurements, no clinical assessment. This is a questionnaire and a phone call, but the owners were pleased with the result. This study here with small dogs with a TTA showed again good clinical results, and they looked at the dogs during an examination. So the osteotomies seem to work and give good result in these small patients. A resident of mine and I, we also did publish a study with TTA rapid in small dogs. And here you can see something which is standing out a little bit is how quickly these dogs improved. So excellent means no visible lameness. And these are dogs 6 weeks after the surgery coming back for the first radiographic control, and 2/3 are lame-free. So this is a very, very quick improvement compared to maybe the TPLO. There it takes longer time until the dogs start to use their limb. The owner rating is very good. They're very, very happy. There is no big problems. Most of the dogs can use the leg totally lame-free, or they can do very heavy exercise before they start showing some lameness. Most of the owners are very happy with the procedure. So these were the results after 1 to 2 years. But during this study and working with small dogs and the TTA Rapid, we realized that the smaller dogs, because they have a higher TPA compared to smaller dogs in my clinic, larger dogs, you see it's 7 to 10 degrees bigger here, the tibia plateau angle. These small dogs need relatively a much larger cage to achieve the 90-degree angle we want. So you see it's nearly double size cage relatively to the body size. So this did lead to a large cage with a very long osteotomy. And the osteotomies are reaching a critical area here where the tibia is thin and bent. So this has some risk that the tibia can fracture if the dog falls or something happens. So we wished that the osteotomy is shorter, like in larger dogs, relatively, so that the osteotomy is behind the crest and doesn't go down so long the tibia. So we had discussions at the Leibinger company, and then the decision was taken to completely redesign the TTA Rapid for the small dogs. It's called now TTA Rapid Tiny. So this set is separated from the larger dogs, and it's developed for small dogs under 15 kilos and cats, and we can use it with a much shorter osteotomy so that we don't risk to go too distal. And you can see, for example, the development of the 3mm cage. This is the original one, and this was an intermediate stage, and this is now the one which is in the tiny set. So the ears for the fixation screws is much more narrow, so we can do it in very small dogs, and the necessary osteotomy is much shorter. You can see this here. This is the same type of dog, 6 kilo Bichon Havanese. This is with the original TTA Rapid cage, a 4.5mm. We achieved what we wanted. We have a 90-degree angle here in full extension. So very happy with the surgical result, but the osteotomy is very long. Now with the new tiny set, this is also same dog, Bichon, 4.5mm size cage. Again, very happy with the result, 90 degrees in full extension. But look, the osteotomy is much shorter. It's behind the crest where the bone is still cancellous. So we are not ending down here. So the risk that we get the tibia fracture or something happening is much, much lower here. And since we're using the tiny set, I have not had a major complication. And it's a very safe type of surgery. We can go down to very small dogs. This is a 2.7 kilo Yorkie. He got a 3mm cage. Down here is the tarsus, here's the implant. That's my thumb, so you can see how small these implants are. And you can see here again, the osteotomy is very nice proximally. It's not ending down here. It's much better for these small dogs, less risk. Cats can be done. They have a very small crest because they are cats, so there's not much space. But with the tiny set, we can use them. This is a 4.5mm cage again, and cats are very happy with having an osteotomy. They show very quick recovery and very good results. Another point we have to consider when we are looking at the small dogs, which come in with the cruciate disease, cruciate rupture, is the fact that quite many of them, up to 20% in the literature, have a patellar luxation or a tendency to have a medial patellar luxation. And the cruciate rupture aggravates the patellar luxation. So that's something we have to address. At the same time, we address the cruciate disease. And the TTA is quite a perfect way to fix this, because we advance the crest to stabilize the cruciate deficiency, and then we can move the crest laterally to fix the patella problem. This is in one step. So that's why you find in the TTA sets these washers, which you can use to keep the crest lateral. You see it here is a washer, so this crest has been moved lateral until the tibia and the patella is nicely aligned with the femur. You can see the same thing here in this very small dog, a Yorkie again, under 3 kilo. He needed a 3 millimeter cage to treat his cruciate deficiency, and to help with the patella, we had to perform a sulcoplasty, which you can see here, and move the crest again laterally using a washer. So this is post-op picture. Here you see the patella is now nicely lying here, little washer, and these are 4 weeks control picture where everything starts to heal in. You can see the patella is in place, and we achieved the goal of 90 degrees patella tendon angle in full extension, and the dog is walking very nicely, so I was very pleased with this surgery. And to have a little bit more results, which are not just subjective and owner perspective, we mounted a pressure sensitive walkway in our clinic and updated it so that we can use it also for small animals. You see, this is a very sensitive long force plate, if you want to say so, and it's used for gait analysis in humans. But we can also use it in small dogs. You see here, that's a very tiny dog walking and trotting over this long force plate, and all these steps can be taken for analysis how the dog is performing or his limbs. You can see many parameters are measured each time there is a step, and then we normally calculate the symmetry index of all these parameters so we can see how the left hind leg performs in comparison with the right hind leg, with weight and stance time and impulse. So this is a very, very good tool. We get out a lot of information. We took a group of healthy small dogs from our clinic co-workers and let them walk over this long force plate. And you can see this is how the control group performed. As we were expecting, the hind legs and the front legs are completely symmetric, so one means there is no difference. This is the peak, the weight on the limb as an example. And what we also can see is that the front limbs are carrying more weight than the hind limbs. This is also normal in dogs, and the factor is about 1.7. So these are completely healthy dogs. Then we took a few patients with very mild lameness, hind limb lameness, and we just wanted to see, can the machine detect this lameness? And the machine can, of course. You can see here we have a significant asymmetry. It's not one anymore. It's very mild lameness, something you barely see by eyes. And what is very interesting is that we can see that the dogs start to put more weight on the front limbs when they have pain in the back. That's something you don't see when the dog is walking or trotting. If the dog is more lame, the asymmetry is very clear here, and all dogs had more weight on the front limb than the hind limbs. So we can use the symmetry of the limbs, and especially here to the weight on the front limbs to evaluate if a dog has some pain in his limbs. So we took TTAs back 2 to 4 years post-surgery. And these are the normal control dogs. And here you see a unilateral TTA. And I think you can agree with me, the dogs are walking completely normal. The hind limbs are symmetric, the front limbs are symmetric, and there is no weight shift to the front limbs. So these were 10 dogs we could get back after so long time. So we were very pleased with these results. And then we also had a group of dogs which had a bilateral TTA over the years. First one leg, then the other leg, this can happen. And also these ones are significantly normal, if you can say so. So there is no difference, no significant difference between control dogs and dogs which have both hind legs operated. You see, they are not putting any more weight to the front limb than a normal dog. So these are really nice objective results, confirming our clinical results that we and the owners see a normal dog after a TTA. So now, okay, let's do always TTA in these little dogs. We have such good results.
Introduction. I just want to really appreciate you being here. I'm very, very passionate about the benefits of both massage and exercise for our pets, and I think an integral part of that is what
that on your
do
screen, Dr. Schmolko?
I often say
someone. I could hear someone speaking, but I could not see a question.
Okay, everyone's muted. Sorry about that.
Yeah, can I go on?
Yes, please.
Yeah. Okay. So when you are dealing with small dogs and cruciate disease, you will get some amount of patients which have an excessive tibia plateau angle. So this is an angle larger than 35 degrees. And there the TTA and the TPLO are coming to a max. So the necessary TTA cage is probably, or is in many cases, too big. And the rotation needed during a TPLO is too large. So these patients are very demanding. It's not easy. So one solution is to do 2 osteotomies. So first a wedge, a cranial closing wedge of the tibia to reduce this tibia plateau angle to normal, and then perform a TTA or a TPLO. So 2 osteotomies. That's why it's so demanding. But in recent 2-3 years, there is a new osteotomy now getting more popular, and that's the CBLO, the CoRA-based leveling osteotomy to treat cruciate deficient stifles. So we were thinking, could we use this CBLO in our small dogs with excessive TPA? Because this is a combination of TTA and TPLO. So it doesn't need to be so extreme, and maybe it could work. So we decided in our clinic to do a group, a little study, and we did CBLOs in small dogs in the year 2018 to 19. It's a group of 15. So just to see, can we do it? What type of complication we get and what results we get. And we were very pleased. So we had no major complication in this group. And again, we noticed these dogs recover very quickly their limb function. So we were very pleased with CBLO in these little extreme cases. So here is some radiographs, how this looks like. Very excessive tibia plateau angle. This is post-operative. So the aim is to have a tibia plateau around 10, 12 degrees. We don't have to rotate it so much like a TPLO because we are also forwarding here the crest. So that's the combination. So this was one example. Here we have 2 Jack Russells, very demanding short legs. Again, excessive TPA. You see here the 4 weeks healing, so it's nicely healing and bridging the osteotomy. And the dogs were doing clinically really very well. We did also cats, a few cats. They also improved very fast after the surgery. And so after half a year, we sent the same questionnaire to these owners, and the result is at least as good as the TTA. So the owners were very pleased. All dogs improved. The owner says an excellent surgery. So we were very encouraged with the CBLO results. A little problem is, as you can see here, there is no CBLO plate available for small dogs. So we use different types of plates. Sometimes a TPLO plate reversed. So it worked, but it was not really ideal. So we started to discuss again at the Rita Leibinger company what we could do. The background, we have very good results. We also try to put these CBLO patients on our long force plate, and you can see again normal walking. There is no difference to a normal control group. So very, very good results. So the Leibinger company has developed these CBLO implants, titanium made, anatomically formed for medium and large breed dogs. So we use this now on a regular basis. So we had discussion, should we do the same thing and go forward and make anatomically formed CBLO plates for the small dogs? So yes, the decision was taken and the implants were developed. They look a little bit different because small dogs are not the same like a large dog. And this is how it looks like. I was very pleased that I got this first set now. It's not a long time ago. And you see we have the 2.0 plates and the 2.4 plates, the left and the right one with all the instrumentation necessary, a small mini jig. And after I got this set, I had to wait a few weeks until I got the first patient, which did suit. So this is patient 1 with this set. And the reason to do a CBLO and not a TTA is this very, very thick cranial cortex. So if the osteotomy, it has to stay behind the cortex, it would have been very difficult to move the crest cranially without breaking this thick cortex. So I decided to do a CBLO. This is the implant just before closure. This is the post-op. You see these implants fit very nicely now anatomically. A day later, we did this one, patient 2, which is a little bit bigger, a little bit longer legs, 7 kilo. Again, we noticed that the implants fit nicely. I don't have control radiographs, not yet, because they are so fresh, but the patients came back for control and rehab. That is patient number 1. And before the surgery, the dog was non-weight bearing for 6 weeks. So he did not use his right hind leg. And this is 13 days after the surgery. He's coming for his first rehab and to removing the sutures. Still a little bit careful, but he's using his hind limb. You see the operated one. The owner is very pleased. This one here is amazing. It's quite a lot of osteoarthritis already in the head and meniscus damage. So we can say nearly lame free. You see here in rehab, walking in the treadmill. And this is just 12 days after surgery. So very encouraging result, which in my experience of several hundreds of extra capsulars, I have never seen in so short time, this improvement. So as a summary, I can say the current situation is that small dogs with cranial cruciate ruptures are often treated conservatively still. And if they get surgery, it's most commonly an extracapsular suture. Unfortunately, we don't have published data about this extracapsular suture, how well the dogs perform. I can say that the TTA Rapid Tiny is a very reliable implant and we have good results. And according to the measurements on the pressure sensitive walkway, restore a TTA Rapid Tiny or a CBLO, the hind limb to normal function measured after at least 6 months after the surgery. So I thank you for listening. I hope I could give you some ideas to think about when you have your next small dogs with a cruciate. Yeah, this webinar was a mix of my own experience, the development of the plates I did together with the Leibinger company, but also what is published so far. It's not so much, but that's what we have. And if you have questions, I think maybe you can ask them now or later. So I give the word again back to Jenny.
Thank you, Dr. Schmokel. That was great. Yeah, if anyone has any questions, feel free to unmute yourself or put them in the chat box, and we'll go ahead and read them to Dr. Schmokel. We also have a new CE course virtually that will be published next week featuring Dr. Schmokel on the technicalities of the TTA Rapid. If you're interested in that, we will send you an email with that information as soon as it's available, and that is for CE credits as well. But I'm not seeing any questions come in, so thank you for your time, and especially thank you, Dr. Schmokel. That was wonderful. I hope everybody has a great day, and hopefully we'll talk to you all soon.
Yeah, thank you that you invited me. Okay. So have a nice day wherever you are listening. Bye. Now I have to go back and do a surgery in the clinic. Bye.
Good luck. Bye-bye.
I hope I don't need luck. That's dangerous when the surgeon needs luck.
True. Just do what you do. Do what you do.
Yes,
Okay,
exactly.
bye-bye.
Try. Bye.